the years is that a lot of people who tend to work in neonatology love neonatology because it's so regimented. Because, you know what's going on at 3 o'clock. It's handover round for nurses. And so everything has a specific order. So we tend to be working with people who like a specific order, who can, as some of the neonatologists, they also like the fact that they can control everything. If the CO2 is high, you just fiddle with the machine and the CO2 comes down. Life becomes very predictable. It's not a bad trait at all, but when you want to adjust to 27-week-old babies, and when you want them to have better brains, and you want to communicate with them, all of a sudden you have to listen. And the worst thing of all is that you have to, or you want to consider what they're saying. So when the baby is telling you, "I cannot handle any longer, I can't handle any more," to have the sensitivity to say, okay, that's fine, we'll see what happens, what we can do about this, how we can go on with your day, or how we will manage to facilitate that. So that is actually one of the hardest parts. The way I'm looking at this talk, I'm going to give you an example of how implementation can go. I'm well aware that each and every one of you works in systems that are very individual. So this is not a cooking recipe. It's a way that I've experienced that my system went. And about 2/3 into the talk, I'm going to show you videos of everyday events in a NICU. And hopefully you will have learned to look with slightly different eyes, so the videos won't be seen that, been there, done that, boring, but that the videos will help you to open your eyes more specifically, and we'll see how that goes. And I might prompt you in the beginning or leave you with the images, and then we'll talk about it afterwards. So that's what I'm figuring. So like I said, you go from protocol-based care, and don't get me wrong, I think that evidence-based medicine is one of the biggest advantages of the last 10, 15 years. When I'm looking at some of these slides, I go like, that is 2007. That's like, no, not recent, but that's, what were we doing before? It's like, what did we know before? I mean, that's one of the astonishing things about neonatology, that we're increasing our knowledge so rapidly, and we then have to adjust to what we know. But to go from the protocol-based to a patient and family individualized developmental care is sometimes quite difficult. And again, I'd like to use Linda Gilkertson's words, that you need to be thinking of safety, protection, and intimacy. And then you have to ask yourself, this is an old picture, and I could actually show you a video film. Let's not go there. This is a setting that most of us recognize as a hospital bed in a neonatal intensive care unit. And then what we did is ask ourselves, is it safe? Does it feel protected? Is it in any way intimate to be here? And what we did, my coworker and I put her in a wheelchair, and we pretended that she was going to have a baby, and I was the nervous father, and we went into the hospital armed with a camera. And we made some pictures, and these are old, and they have been replaced. Unfortunately, we're moving into another hospital building, but these were elements of home-like situations, all these birthing cards of children who were born in the hospital, and these decorations. And this was actually a decoration specially made for the Mother-Child Center. You can like it or not, but it's sort of playful. And then you get there, and then you think, so am I really welcoming? And we were here, and you can see that when you are in the wheelchair, you can barely reach the door open sign. But then you get here and there's no one there, and it says Mother-Child Center, and it says maternity unit, and you're not supposed to use your phone, of course, and there is no one. And we were sort of wandering around, and then suddenly the secretary appeared from somewhere, and she said, after 4 o'clock, this is what the parents will see. So for most of the time that parents come into the maternity center, this is what they see, a locked door. So only between 8 and 4 you see this, and there might be somebody welcoming you. And then there's this door that says stop, stop, stop. And the door opener, and then you go in, and then it says stop again. And if you can see it, there's a little bell on top, but you really have to be very ballsy to be able to really go and press that bell. Fortunately, there are nurses behind here who will have seen you come in, and they will guide you to this room. And there's a sort of a pre-examination room where you have CTG machine, and they will do an evaluation of what you're doing. But on a busy day, you'll be sharing the room. So, you get your gynecological examination, and there is a curtain though, but if it's painful, then you might be ashamed to make some noise, or, and certainly you can't have all your cousins present there. So you're basically there on your own. And then when the time comes, you're invited to this, and this looks a bit sketchy on here, but this is the first thing you see when you come into the delivery room. And I've been around the globe many, many times, and I've seen many delivery rooms, and I've seen so many trash bins. That was like the first view you get of a delivery room. Is the trash bin, and I know, I know it's functional, and I know I shouldn't be bothered, but the sign it gives, like, if you don't like it, you can just get rid of it, and it's that whole attitude of practicality. And I don't know what happened to the slide, but anyways, and this bed, the last time I saw a bed like this was in the torture museum in The Hague. It is very hard, and has all these things to it, and then you have to put your legs in, and I know we've all been there, and a lot of you have had actually your babies on that bed. But the question is it really, really necessary? And I've been to Germany where they have more naturally formed beds, and they also have possibilities that you can stand up during your labor, and that you can hold on to something, a more, I think, woman-friendly environment. And you have actually these benches where you can both sit on it, and your partner can sit behind you and hold you or massage your back. And this bed is for us. It's like then we can view everything much better. And of course, we want to be safe. I mean, don't get me wrong, to think about safety and protection of the child who's going to be born here. But the question is, does it really have to be like that? And on top of it all, we have this door, and on my computer it's a bit bigger, but it is distorted. And this door has a little window, and I'm looking through it, and behind this door is our resuscitation room. We do not resuscitate within the presence of mother, and which I haven't been able to change for the years and years I've worked there. The thing is that one of the residents one of our pediatric residents, and his wife delivered in this room, and after he was working again, he sought me out, and he said, "Nick, I have to tell you, every time you remind us of the things we do," and then when I was sitting there as a father, and my daughter was born quite blue, and she was rushed away to the room here, and I was staying with my wife, and after a couple of minutes, well, maybe 5 minutes, the baby came back all looking rosy and pink and lovely, and the only thing I could think about was, they've changed the baby. I mean, the most horrid emotion, they've changed your baby. I mean, what does that do for your bonding, for your experience, for that whole sense of belief and trust in the system? And he said, it is so weird that I have worked in that room. I know exactly what goes on. And yet I had this feeling they have changed my baby. And so then I asked, what is this cabinet for, and why are all these things here? And nobody has ever used anything that's in the cupboard. So I asked them, why don't you just remove it? And more of those questions. And we have this big mirror screen that the students and then the gynecologists, everybody can stand behind it, and you can look into the delivery room. And it has a text on it that it is a see-through one-way screen window, and you can ask them to close the curtain. But because of hygiene, the curtain is not on the outside, the curtain is on the side where we are standing. So who says the curtain is closed? So these are all these signals that make the environment uneasy. And after I showed these images to our department, this room has been pimped. They put some paintings up, and it made it more family friendly, because this was the nervous father waiting room if he didn't want to be with his wife. And these are the corridors which are quite generic. And you've seen these images, so I won't go on and on. And so this is quite different. And so these are all the different images. One of the things that the effects of my lectures sometimes have, that people go home very enthusiastically and they know it all about NIDCAP, and they buy all these gadgets. These are sold and by American industries, medical ventures. I don't work for them. This is not a commercial. But the thing is that you can ask why this big baby should be in an incubator in the first place. I hope you get a good view. And this was a unit I worked with, and they were building a nest. And they were using the materials. The thing is that a lot of people, they think by covering an incubator, but I think this was the most hilarious portrayal of what I sometimes feel like Santa Claus. Or St. Nick's in Holland, I come somewhere and people adjust their behavior. Like people will spontaneously start whispering when I'm there. Or this one unit I came in, and the moment I came in, I heard tick, and they switched off all the lights. And then we had to do an observation of a baby. And so this is not individualizing care. This is just, you know... Not even for me, not even for me. This is to make them look better. But like some of my trainees say, you have radiology eyes, you can see through anything. But the thing is that you need to know what you're doing, and you need to know why you're doing it. And so using all these materials, and some of them are really well to use. I mean, is it really helping the baby? What are you hoping to achieve? The first question, people ask me, so is this beneficial? And I say, why are you asking me? And then look at me, well, you know. And I'm like, you have to ask the baby. You know, you have to look at the behavior of the baby when you've done it. And he is going to be the one who's answering your question. And you have to be pretty mature to listen to the baby, and then to comply with what the baby is telling you. So this baby is to me, when I looked, I mean, she had no contact. In a way, she wasn't asleep, I think, when I saw her. And she had no cozy covering around her head, and her leg might want to go somewhere else, but it sort of got stuck between all these almost like bandages. And she certainly can't do a foot clasp, and a foot clasp, touching your feet together like a hand clasp, is one of the best ways to self-regulate for a baby. So, you know, not being able to feel your own feet, and this was part of a whole process. We looked at the baby, and I asked to take this picture. And then the big issue was, in this unit, it was a cultural thing that you could not do kangaroo care. That was just not a possibility. The unit was crowded, and yes, it was crowded, and yes, it was in another country, and so I asked, you know, where is the mother, and tell me, you know, can I work with mother? Can I talk to her? And she spoke some English, and we sat together, and I said, so what would you normally do? What would you like to do with your baby? And she just stared at me like, what kind of question is that? You know, it's like, I can't do anything with my baby here. And so together we got the baby out of the incubator, and she was pumping her breast milk, and the baby was sort of big, was awake, was making contact, and had some sucking movements going, had a good saturation. And I said, "Have you ever had her on to your breast? Has she ever latched on?" Or, oh, and then people behind me were sort of going like, not part of the culture, not in our unit. So we had a screen around the bed, and it was all very crowded. So the baby was with the mother, and the baby latched on, and for like 5 minutes, she sucked some milk, or she sucked some, and then the chair was quite comfortable, I must say. So we lowered the chair a little bit, and there was still some sitting and some breastfeeding and some enjoyment. And slowly, mother fell asleep. I withdrew, and I just let her with her baby and withdrew. And mother was sleeping for quite a while. And everybody was just looking at me like, okay, it's not part of our culture. And I'm like, duh. So together, and then afterwards she had to go back into the incubator because, like with all change, you don't want to push your luck too far. So we made a nest. And what does a nest do? A nest is supposed to support flexion. The reason why we want to support flexion is because your brain at that particular period between this 24, 36 weeks is working on extension. The movements of your limbs are extending. And because the brain is also it's a miraculous organ in a way that why should the brain focus on flexion when flexion is the constant possibility inside the womb? When there's little room, why should you practice flexion at all? So the system is first trying to extend and see how that feels and how that goes. And later on in your life, when you're trying to learn to ice skate or to ski, you first sort of intuitively or panickingly, you extend. When you fall, you tend to extend. And when you become more fluent in the movements you're making, or more secure, then you're able to make some flexions and so on. So from birth on, we want to emphasize flexion. And when the baby is learning or trying out these extending behaviors, or involuntarily has morose or kicks out because your hands are cold, and so then the baby needs to come back. So that's the whole idea about why we like this fetal position so much. And of course, when you're flexing, you can have your hands near your mouth, you can have your feet together, and you can nuzzle up, and you can go back to sleep. When I try to make changes, or when I'm part of the architectural committee in my hospital, and to get people on board, I also emphasize the fact that the staff needs to have a good environment. How can we work day in, day out for so many hours a week when there's no support for staff? When you have one chair and you rotate, or you have a little kitchen with an espresso machine or with a boiling thing, and many hospitals still have no space for nurses to sit. I mean, as a doctor, I can escape, I can go away, I can go to the coffee shop and appear busy, but as a nurse, you're stuck. There, you can't even put your purse somewhere, it's sort of, and so to have a room for staff is incredibly replenishing. If you've had a baby dying, or if you've had a rotten morning because of things that happened, to be able to sit down and just have a coffee and in some peace and quiet, in some nice environment, that's essential to replenish. So how do you go about making change? Change, if you want to make change, you got to start looking at yourself and seeing, okay, who am I? So in Rotterdam, when Heilise Als visited us, she said, I want you to show me something quintessential of the city. And we used to be the biggest harbor in the world. Now we're the 6th biggest harbor in the world. And we made a harbor tour. We had a boat, and we just went through the harbor. And these were some of the images that I see from my window. I live in the harbor. And Heidi was so astonished with the fact that everything was so meticulously in place, and everything was in order, and there was a system to it. And of course, she loves those things. And it was big, and it was rugged. And so how are the people? I said, well, the people in our city have no words but action. It's like the city that are made of doers. It's you have to perform, and let's not talk about it, but let's just go, 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 go. And then the working group, because when you want to study yourself, you in a unit, you do it with a group of people, multidisciplinary, like I said yesterday, and they looked at what would we like to change, because we can't make it all change at once, and what in our unit would be the one thing that would make a difference that we would be proud of. And we were still using very thick tubes for CPAP, and nasal CPAP tubes. We actually still do, and we have 3 or 4 different CPAP systems, but if all else fails, people go back to what they're most used to, so this one prong nasal CPAP. And so this is actually the tube. And to insert this, I mean, you see a lot of stress behavior, and you see discolorations, and you see apneas and bradycardias, and it was very stressful for the baby. And what we said, we have 4 different units now, and 3 intensive care units, and they're all basically the same setup. So we started in one unit and see how that unit reacted, and after 2 months we would move to the next unit and give information. Of course, everybody was chatting, so we need to beforehand say, okay, we would like to do some research, and we'd like to say, okay, if we change this, what does it affect? And but everybody has to work with this. We knew from our environment that the academic hospital, a lot of clinical research is happening. So people are used to complying and doing things that they normally don't do, but it's for research, so we'll do it anyway. So this was also introduced in that way. So it was actually forbidden not to, co-regulate a baby during this whole procedure of CPAP change. So people had to actively ask each other, could you help out? They were used to coming in at 7 and then doing the first round, everybody at the same time at 8, but how am I going to help you when I'm already doing something? So people were forced to communicate with each other. If we had said in Rotterdam, I want you to sit down together and talk about this, people would have looked at me like, are you out of your mind? Like, we are doing this and we're not talking. And so you find different ways and trying to reach that goal. Anyway, so very direct and saying, okay, this is going to happen. And some of the remarks I wrote down. And we had some remarks, it's ever so busy and there's no colleague to help me out. I simply forgot about it, or it's very difficult to plan. It's just like not doable. But other people said it's less stressful for the baby, it's less stressful for the caregiver. And because we made people do this, people who thought, and this is also the psychology of people who work in our unit, I am super nurse, I can do anything, I can do everything, I can talk to parents, I can use the machine, I can draw up antibiotics, and I can talk about my vacation in the meantime, everything, I control everything, and that's the mentality. And all of a sudden you have to be asking people around you, and you have to show your vulnerability, which is difficult. And this was 8 years ago. And what it has brought us, actually, is that because we were telling people that they had to do this, that eventually they got used to it. And then we had crew management training, which means that you have to, for safety reasons, double check your medication, and you have to ask your colleagues as well. And so asking became more of a habit in our unit, and nobody believes that they've ever worked like that before. So the unit changed gradually in that way. And because people always keep saying, you know, you cannot do NIDCAP because we have 2 little nurses and we take care of 3 babies, and sometimes in night shifts there are units out there in Europe that take care of 8 babies, and so there was always this nagging of reasons why we cannot make this happen. outside of ourselves, because I think it has to do with ourselves, but we don't like to be vulnerable. So we find things outside of ourselves to blame for things. So what happened was, in our part of the country, we also have difficulties to find nurses who want to work in neonatology. So we basically have 10 job openings most of the times. We have a crew of 150 people, and there are always these openings for nursing spots. So the manager actually sat down with me and she said, you know, couldn't we use nurses' aides? So we free up time from jobs that nurses don't like to do anyways, and we have other personnel there, much like the Swedish model, having nurses' aides, and we had money for that. So they re-budgeted. So this comes back into how do we deliver care, and how can the system support that care by rethinking some of the models that are going on. And so we had nurses' aides, and the nurses' aides are they're not highly educated people, and they, in our unit, are also differently educated, coming from nurses who took care of old people, or nurses who were working as domestic aides for people with medical problems, so different people. And what we've seen when we took on the first 6 of them, there were 2 per unit, 1 in the morning, 1 in the evening, and what we said is, okay, we looked at these people, and some of them, they couldn't do arithmetic, so we couldn't be asking them to deal with milk distribution. Like they couldn't help the nurses to bring the bottles, because they just couldn't deal with how many cc's, and I mean, there are lots of different problems. So after a month or 2 of monitoring this group, we sort of saw what are some of these people good at, and then we started to differentiate. So within that group, people are doing different things as well, and they are also working together. And some of these women have gone on to shine and have actually become breastfeeding consultants, for instance. So, and not every one of them, because the other one, she manages the whole supply system for all our supplies, and so they've grown into specific jobs. So in a way, what I'm going at is, you try to build a community that works and lives together and complements each other. So it's a different way of thinking. So another one of the strategies was, this is in this old poster, and this is the original poster. And what we've done, every year we sit down at the end and we say, okay, looking at our wish list, what should or what would we like to have happen? And what we did was, we looked at all the challenges that we found, and this is environment, for instance, and in the environment we would say, okay, what would we like to change? We needed more curtains, we needed partitions, chairs, parent room, breast pump expression room, and all sorts of different new supply rooms. All these things were put on a wide list, and were then distributed. We would say, so in the first 3 months, what could we change? In the second 3 months, the next trimester, and the next trimester. And then we had like a shopping list that you could check off. And we made somebody responsible for some particular issue. If you are going to look at supply rooms, then your name is on it, and then you make it work by August. You know, that's when that issue needed to be tended. So in this way, you make it very transparent, and you make people accountable, and they can live up to what we were expecting. Also for parents, how do we talk to parents? How do parents make appointments? All sorts of different issues, and caregiving and support, like the CPAP system. And we had our own agenda, individual observations. So as to this is almost 9 years ago, the developmental specialist still working as a nurse with the other developmentalist, videotaping the care. And what came out of this whole videotaping was called the individual clinics. So what we thought of is, we can lecture all we want, and people will listen to it and they will enjoy it, but what about ongoing education? So the individual clinics meant that the nurse would take care of the baby, we would videotape the whole caregiving, and then the nurse was able to go out of the unit together with the developmentalist, and they would then together look at this videotape. And then the nurse was asked to respond to what she was seeing, not what she was doing, but what the baby was showing her. And then they discussed what they could do for the baby differently, and afterwards they would go back to the bedside and do another caregiving in the next round. This system only worked with 2 nurses at the same time, and they were being able to take care of each other's children. So we were already basically communicating quite well at that time. This has made the biggest difference during that period. And of course, when you want to move away from the bedside, because the endless discussions of doctors around the bedside and not even looking at the babies, and we took them away from the bedsides, and you have to set the example. And this was actually the decision, the change that the nurses liked best, to sit down for rounds and not hang around the bedside. Education, like yesterday, you want to make sure that people know what's going on. You do not want to come in and say, today we're going to do this, and just walk away and expect people to do it. It doesn't work that way. You want to explain why, you want to give rationale, and in Holland you need a bit of discussion with that. Maybe less in Rotterdam, but certainly. Now, this is one of your exam questions, so be mindful, Italians out there. In any change process, and the reason I'm pointing out to it, because a lot of doctors have learned from this, that in every group there are like 4% pioneers, people like me who like to do new things and without thinking, just try it out and see what it does, and new respirators, new IVs, new anything. And that's just the way we are. And then you have people who think it's very exciting and who follow very quickly, don't need a multi-center randomized controlled trial, or better still, Cochrane reviews to accept what's going on, what's new. And then you have the people who basically go with the flow and they accept very quickly. Then there are these people like, oh my God, he's got something new. Well, the slow acceptors. But then after a year or so, they go like, there might be something to it. And blimey, yeah, and I don't want to be like the only one not doing it, so maybe I should do it. And then you have people who I never understood before, 15% who will just refuse, who will absolutely not change because their psychology does not allow them to change, because they need that structure, because their brain cannot expand any further, plasticity is going slowly, and they refuse. So I used to spend time with people, with refusers. I would used to, like a religious person, I would go to the refusers and try to convert them. And I know that that's a loss of my energy. It's a waste of time. You do want to include people like that all the time. You want to give them information. You do not want to become prejudiced, not like them. You just want to be this open person who is always ready to help people along. But, you don't want to think that you can change these people. And in a way, change doesn't come by changing people. We change ourselves. So we make that decision, or we get used to different ways of doing things. So that's what we do. This is an old video. These are not seizures. This is not Roberta's talks. These are twitchy movements of discomfort, actually. The autonomic system is, and what you see, this child was under the lamp. Hold on, I'm going to talk you through it. This child is under a Billy lamp. Billy lamps are very tiresome for babies. I mean, there's not a baby who lies there and thinks of the beautiful tan she'll be getting. No, Billy lamps are hard. And even when they have this mask on, they shouldn't be seeing any light to protect their eyes. But still, what happened here and why I stopped was when you turn the lights off, the baby stopped moving. So I don't know how the baby knew that something was up or what happened, or maybe it's just coincidence. But there is something moving, and now the baby, she also slowed down her breathing, and now the breathing is coming up again, and he starts moving again. So there was a shift in something in the environment, and the baby might have reacted to that shift. So again, the nesting is not perfect, but there is some flexion in the hips, and these are quite heavy actually, and the saturation monitor. This is another view, again under the lamp, I think. Unfortunately, these videos have been edited to show specific things, but what it shows quite nicely is the knee to foot clasp. And again, the lights go on now. The baby doesn't really change very dramatically. And so what we like to do always is, even though the light, even though babies can't see a lot but shady, darkness, shadows, we do want to open up that at least if, that we think that he might see us coming. And this can take a while. So that's why we sometimes don't. Why do we just, and some people don't even bother to turn off the light, the Beely light. So they just, leave the light on and that's it. So what we like to emphasize is that you ask this patient, can I come in? And you announce yourself. What we tend to do, and don't say you don't, because what I see sometimes is the doctor has the stethoscope and just plants the stethoscope on the baby, has the other hand somewhere else, but no contact with the baby, just the stethoscope on the baby, and then goes to this tummy. And then you have to examine the tummy, and you just go into the tummy, and then you go out again, and that's it. What we would like to see is that this baby has no clue what's going to happen, has no idea. So in the whole matter of, are we safe? Am I safe? What does this baby need to feel safe? I don't know. We suggest, making a nest, but even in a nest, you can be ambushed by a cold stethoscope. And so what we try to do is, okay, you make contact so that the baby might realize there is something changing, and then there's this hand or this warmth or anything, it's on me. And you try to stabilize that hand, and with the other hand you move around. So this becomes the predictable factor for that baby's brain. So this is, when it not changes, this is what the baby can sort of use for safety, or has sort of a factor. The baby has no idea whether this is going to take all day or just 2 minutes. That's the other thing. It has no sense of time. So when you go in, you touch the baby, and you go out again, and you go in again, and you go out again, the baby has no sense. It just gets disrupted the whole time. The baby does not build up a trust with this hand. It just feels that it's there, and then it's not there. It's there, it's not there, it's there. So it's confusing. So that you disrupt the environment. And then very carefully, you need to examine a baby. And I sometimes think I'm just performing a ritual, because how many times do you really hear the atelectasis without you already knowing that there might be something going on in that lung, and that the radiology will need to come to make a picture. So it's part of how we deal with our patient care. And some of doctors have actually said, we might not even need to examine the baby that closely, but it's debate. It's a true debate, and trying to show, and it's difficult. And you see that the baby is actually moving about, and you might think that it would be too much at the moment, and then you just wait a while. So in a way, you need to move slowly. And the baby's, the Velcro was stuck again to the diaper. So these are all these disruptive things, and you open the diaper to look at the bed, to look at the stomach, and to inspect the umbilical and things like that. In this case, feeling the femoral artery, and this. So again, I think, yeah. You see, you give some pressure, and the baby immediately starts moving about. And the doctor is very determined. He needs to do this, and so needs to have the legs out of the way. Sometimes when you have these small for gestational age babies who are very motorically disorganized, then we sometimes have another person there to co-regulate the baby. So I'm going to go through this a little bit, just highlighting some of the things. Again, you saw this video with in the first lecture, this baby who was trying to co-regulate himself by trying to get his hands near his face, but wasn't succeeding. And it's just motorically all over the place, not being supported well enough by the nest under the Beely lamp, and the lamp goes off. And there's this short pause, or the nurse comes in, and she actually makes contact very slowly. Instead of being determined and doing all sorts of things that she might want to do, she tries to first establish some contact. And of course it's edited just for purpose. And then, you know, the baby, just that first contact takes a while. And sometimes you give a pacifier, and when they want to take the pacifier, they do that. And the nurse is actually using some aid as the blanket is over the baby, enabling the arms to stay in a flexed position, not tying the baby up, but just adding some weight. And when the baby moves about too much, then she'll stop. And yes, this takes longer. And sometimes you want to regulate the holding of the baby, like with your hands. Sometimes you need some little more pressure, sometimes you don't need pressure at all, but just to be near the baby, because you do, and this is also very difficult at times, that how much regulation does the baby need? That's what you need to learn from this whole sequence of interaction with babies. Okay. We had this huge debate of what parents can do. And these days we don't weigh the babies outside the incubator. We have different incubators so they can be weighed inside. And this is on day 3, the parents who were instructed by the developmental specialist, and together with the nurse, the father was going to take out his child and put the boy on the scale. So these were all questions of like, how far can we go? What can we do? And we have basically videotaped it for just teaching purposes or documenting what we were doing. Nowadays, I would love to have the curtains closed more and have some less light there. We have darker covers at the moment. And you see how delicately the dad moves his son. And the nurse then, very goal-oriented, says, you can let go now, you can let go now, go now. And that's what she's saying, actually. And then the father wants to, but then he immediately sees that his boy is moving around, so he's going back for comfort. And the nurse keeps reminding him, please let go, because I need to weigh the baby. All the material that is in the scale has been weighed before using the scale. We used to have digits on every single item that was going on the scale, pre-weighed, and we just wrote on the diapers and everything. Nowadays, we basically get a notion of how much everything is, and we can adjust all of that. But when we were first starting out, we were using it. And just to have the nesting on the scale was a big change for that period. And sometimes they would use a clean nesting, would get rid of the old nesting in the incubator, and then take all of the nesting back into the incubator. So it would, thinking through your steps and involving parents in the care, because we did that because in our own research we saw that parents felt they were pushed aside too often and they were not important. When I look at these older videos, I do realize that we have changed our hygiene rules as well, and that also for parents, it's no longer allowed to have long sleeves, for instance. So this would not go at the moment, and we've asked parents to have short sleeves or at least roll them up so they can wash their hands more thoroughly and use alcohol more widely. So this is how we were thinking through, okay, the patient needs to be weighed, the parents are there, and so we're asking the dad to, or the mother, to weigh the baby. And then after that, and let me speed it up a little, after that weighing, where the baby's, and they would go on to kangaroo care. And what we devised was this, and hopefully I'll catch it, because I don't want to, hold on. What we divide, this movement, the bowing into your baby, so to make that transition as short as possible so that the baby can use the father's body to co-regulate, is essential. This is going a little fast. So the bowing in a way that the transition, because transition for the baby is the biggest fear, because again, the baby has no clue what's going on. So being put from one side to the next, if you take the baby out of the incubator and you basically put him on another surface, that whole transition is like us going on one of those roller coaster rides. So for their body, when you measure their little bodies and the amount of travel they've done, this is actually on the left not a nurse but the mother, just in case you... So this is the big chair that we had brought in by then. And you also need to talk through, the parents also need to talk through what's happening, because the father wants to use the bunting, but the mother insists that they use her sweater. And so these are things that you have to streamline and talk about before you do things like that. And that's what we learned from just videotaping and being with parents and trying to smoothen this out. And sometimes when we look at the video, we think, oh my gosh, what did we do? So many hands touching and not touching and fiddling around, and we need to be more slowly. And this is what you learn from video. Okay, this is mother fidgeting again. So this video was sent to me, again, people who are changing their care, who hear me talk, and they say, okay, we need to do an age-appropriate bath, and I hope this one starts, because I don't know what's going on. Nah. No. Start with what? It doesn't start. No, it doesn't start. Hold on. No, hold on a second. I'm going to show it because it's to me it's a very lovely video, and let me see where I have it. Sorry about that. Videos here. No, it's okay. Okay. The reason I'm showing this is because it signified something that I hadn't seen before, that we talk about, but hold on. So this was made with the best of intentions. The mother is there, the nurse is going to bathe, and they have put a cloth inside the bath because it's iron and they wanted to regulate the temperature. They put some soap in the bath, and the nurse is holding the baby. And for doctors, this is a far cry because we usually don't see what's going on. And so they've learned that the baby can co-regulate himself by using a pacifier, the green thing in his mouth, the pacifier, and they've learned that transitioning you can do with a cloth around the baby so the baby can be tucked in all the time. But like you just saw, the movement going from there to there, and even this, just you have to take the pacifier. This is, again, not complying to what the baby needs, with all the best intentions. Like, people think they're actually doing a fantastic job. And they're doing a better job than just plainly dumping the baby into the bathtub, but, you know, it's still... And this nurse, she says, okay, she sees that the baby is restless, but she's learned that maybe side-lying works, or... And... but to me, you sort of... Inga Warren, my colleague in London, always says, it's very easy, developmental care. If you go, ah, then it's good. If you go, E... it's you know, and this has sort of that sense of the baby is not comfortable in a way. You know, you see discoloration. Baby is not actively sucking. Well, now he is. The hand is near the mouth. So at times it's okay. Baby is not, you know, when you look at this, you ask yourself, what does the brain need to be learning? What is the brain geared up to going to do? And in a way, even though the brain is not ready yet, a lot of premature infants will try to open their eyes when they have the energy and find where the noise and everything is coming from. So they have a tendency to look out. But when they're overwhelmed, they don't look out and they start wiggling their body and in state 5. And he does have his eyes open. And now the nurse gets it. She's like, okay, he's wiggling too much. Maybe he needs more protection. The baby goes down a bit. He's back into a state 3, a low state 4 maybe. There's some sucking going on. There's some holding. There's this holding of her finger. So there's some self-regulation. But the breathing is still not really nice and smooth. And this hand is just lying there. This hand is not joining in on the whole thing. So there's still some sucking. So this is where I would like you to pay attention, is that this to me this is why the reason I show this film is because in this moment, actually now, you sort of see that there's more synchrony. This movement shows me that the baby was reacting. The baby was quite happy when she was doing the water, and then all of a sudden it was too much. He reacted, and she stopped. She put her hand near him. She held the baby. So from this moment on, she became more in tune with what the baby was doing. So now they're actually, for short periods of times, they're doing it together. The nurse has gone away from, I need to bathe this baby appropriately, to, what is this baby telling me? This baby is telling me it's actually been too much. I think in retrospect, what you might want to say, you should have just stopped bathing, take the baby out, and that's enough. But again, we're human beings, we're adults, we want to make a video, we want to make us look good, we want to show our NIDCAP trainer, and all good intentions. But she's significantly slowed down, and she's more, to me, she's become more gentle. See again? She could go to the next level and say it's been enough. And this is how subtle things get. And when you're, because, you know, why do we bathe? You know, do they really stink that badly? And so that's the first question in the beginning. And why can't we show the baby? If you, in a perfect world, you would show the mother how to bathe with a baby doll, with a bathing baby doll. And you would show how things go, and then she can do the first bath herself, if she feels comfortable enough doing it. So these are all these items that are on the list of changing a unit. Now let me go to another film. How do I do this? Oh, there it is. I'm working on 2 screens at the moment. Oh shit. No, it's fine. It's here. Trust me, I tried them before. Okay, we'll go to this one. This is, if it starts spontaneously, I don't know what happened. Yeah, it doesn't. I think something happened. Hold on. I'll go back one. And this is a feeding one. In the question is, what's going on here? When Sunny Anand saw this video, he said that the baby was having a heel stick. you can clearly see that the baby's crying or the baby is in a state 5, messing around. You can see that the color of the baby is quite mottled and uneven with dark and white patches. The thing in his mouth is something they tend to do in our unit, to have the baby suck on a piece of cloth that is drained in mother's milk. So they think it's a nice thing for the baby to do. What happens is in our course of trying to change our care, we were seeing, okay, what are some of the items that we would like to change? And feeding was one of them. For me, feeding is a social encounter between mother and child, and feeding is supposed to be teaching us about being together, about nurturance, and feeding is not just getting the proteins in. And in a busy unit, and in a unit where the babies can't really feed by breast or by bottle milk, we do a gavage feeding. So this is actually what's going on here is the baby is getting gavage fed. So you've just seen 1 minute, and we unfortunately had to tape this for 20 minutes. And seeing that the baby was in a nice nest, we're doing this developmental care stuff, and who should complain, and you just walk away. You give the gavage, you hang the gavage up, and you tend to the next child. You know, this is it. What we never realized was the food. How warm is the food? How warm is the food in your unit? How many Celsius does the food, how much does it have? In our unit, we were forbidden to use the warmers, the water-based warmers, because, of course, obviously, of infectious disease reasons, the Pseudomonas would grow in them. And so it was a very viable, reasonable given that we couldn't use that. So what they did was to take the food out of the fridge, and we would put it well in advance in the incubator to warm up. So we'd say it's room temperature. But what happens on a busy day is, oh shit, forgot the food. So you get it out of the fridge. It's how warm is the food in the fridge? About 4 degrees. So then you put it inside the incubator, and then it warms up. How warm will it be? One of the mothers, actually, when she was kangaroo care and holding her baby, and the nurse was giving the food, and I was standing there in support of the whole system, she said, "Oh, I can feel the milk going in." And I said, "Excuse me?" And she said, "Yes, I can feel this cold streak." So she felt the cold streak on her own skin that came from the milk that was going through the esophagus. So these children are getting ice creams like 12 times a day. And, you know, that is sometimes painful when it's really cold. And what we saw actually was a child who was beforehand was sort of quiet after the caregiving, and then you give the gavage feeding and the baby starts to fuzz around. The baby in this situation is losing a lot of valuable calories just fighting off the system, just by being unrestful. So calories that we were trying to use for brain growth and muscle growth and all that. And so by just looking at all these normal everyday events, trying to integrate and really see and really look what you're looking at and really asking yourself these questions, you get to the care that you would like to see happen. I'm sort of out of my comfort zone with this system that's not responding the way I want it to respond. So I'm going to try to go back to see where I was. I'm sorry about this, guys. No, there it is. It's one or two slides. Presenter view. Okay. So I would like you to direct your nursing staff to some of the amazing work that came out of the early feeding skills assessment for preterm infants. This group actually educates people in a very amazing way, and they go internationally as well and provide people with ways to feed prematurely born infants. And again, with every change, never doubt that a small group of thoughtful, committed people can change the world. indeed, it is the only thing that ever has Margaret Mead, and this was on a fence in Bali, actually. And some of the mothers have said, one of the mothers said, NIDCAP has helped me to overcome my fear and not lose myself. Because I was involved in the care of my son, it became possible for me to transform the fear and anxiety that was within me into genuine caregiving of my baby. I looked at the NIDCAP specialist and copied her behavior and peace. In this way, she helped me throughout the whole hospital stay. And beautifully enough, I think, you know, a sense of party, of paying tribute to all the people you work with, and to reflect in a festive way is what I would like you to remind you of. It's not always hard work, it's also sometimes play, and given in a very supportive nursing lounge where you can sit and enjoy your cake. I would like to thank the organizers again for giving me the opportunity to speak. We have a DVD that is made for parents. It is done by a remarkable friend of mine in Boston, and she has done NIDCAP work as a movie director and a documentary maker, and she's probably won every single award there is out there in the United States for educational documentation, and she's worked with fetal alcohol syndrome, breastfeeding, and also when she found Heideli's Alsa's work, she came to the lab and she wanted to know all about it. She made some educational videos, but she made this video especially for parents, and what some of the feedbacks I got from parents, from different parents, was what I liked about it was that other parents were telling me what might happen or what was going on in their lives. So it wasn't you as the professional telling me what was going on. No, it was people, real people like me, who was supporting me. So that's why it has been such a success. And we actually, when people are admitted to the hospital and they're not in a very acute situation, we play this DVD is shown before the neonatologist talks to the parents, and they can come up with questions that they found in this film. Do you have sound on this as well? Or do you need this? Oh, you need, okay. There should be some sound coming in. Yeah, it comes.
This is not a doctor.
No, this is a professional team filming, and this has been edited by a highly professional team, but it's parents talking, yes. And there is some information there as well about developmental care.
And, you know, you think nothing's going to happen to you, it only happens to other people.
Well, I was expecting